So when looking at the subjective assessment for case study 4, the patient presents with pain in the right buttocks with radiating pain into the upper leg. The initial onset was chronic and it was treated with hydrotherapy with no pain afterwards. However, the pain returned during pregnancy and got worse with referred pain down the leg 3 months ago. The 24-hour behaviour suggests that it is worse in the evenings, but there is no indication that it causes night pain, which is good, as this would be a red flag. If we look kind of at the other red flags that we can see, there's no caudal equina symptoms and kind of no numbness into the upper limb, and so there is no indication of an upper motor neuron lesion, and so there's no need to do Babinski's or Colonus tests. And then if we look at kind of aggravating factors, sit to stand, walking up and down the stairs or sitting for more than 20 minutes can bring on kind of symptoms such as the numbness down and the pins and needles in the back of the leg, and so this could be an indication of sciatica. And easing factors are heat, soft tissue and massage to the area. So it's important that when we kind of look at spinal injuries, we consider red flags. So the client doesn't have osteoarthritis or osteoporosis, because this would be a red flag. And also looking at the area as a whole, I believe that the lumbar or the sacroiliac joint are involved. This is primarily because of the pregnancy. So in pregnancy, a lumbar spine, there is increased lordotic curve due to kind of holding the baby, and so this warrants this area being investigated. The sacroiliac joint, during pregnancy there can be laxity within these ligaments, causing hypermobility in this joint, which causes issues. And then also it is possible that the sciatica may be being caused by tightness in the piriformis, as the sciatic nerve runs through the piriformis, and so it warrants this area being investigated as well. And so if we move on to the objective assessment, we can look at any postural abnormalities and then start to move on to our special tests. So before carrying out the objective assessment, I have made sure to wash my hands and remove all jewellery. My hair is tied up and I have obtained verbal permission from the client to assess and treat them. So this is the objective assessment. What I would usually do is look for kind of all other postural abnormalities, but specific to the case study, I'm going to look at specific things around the lumbar spine and the sacroiliac joint. So the first thing that I'm going to look for is anterior or posterior tilt of the pelvis, and it looks to be quite neutral. And then the second thing I'd look for is a leg length discrepancy. So what we're going to do is get Alice to walk forwards and backwards, and we're looking for an antalgic gait to see if there's a limp. Okay, so that's all good. And then next we're looking for atrophy in the gluteus muscles. So if I come behind, I can see that they are quite normal, but you might see kind of one side is less muscular than the other side, or there's a lack of muscle around that area completely. What I would look for is hypermobility in kind of other joints, because hypermobility in other joints might mean that there's hypermobility in the kind of sacroiliac joint. Alice doesn't seem to have any hypermobility. And then I'm going to look for kind of the levels of the ASIS and the PSIS. So if I come round, I can palpate the PSIS by placing my thumbs here. I'm just seeing if there's a difference in height, and this will be described in tests further on. And then we're looking at the ASIS, which is at the front, as well as the height of the iliac crest. And then lastly, I'm just seeing if there is like a lumbar curve or a swayed back or anything like that, which might have some abnormalities within the spine. I need to clear the joints above and below. So the first joint that I'm going to clear is the lumbar spine. So I'm just going to get Alice to do flexion by coming forward and reaching down for her toes. And then we're going to do extension. So you're just going to do a backwards bend. Is there any pain? No? You're going to do side flexion. Good. And then side flexion the other way. And so there's no pain produced on these movements. I would also look to clear the knee joint just to check that there aren't any abnormalities there. So we're going to clear the knee joint by moving the knee through the pathophysiological ranges of motion. So what we're going to do is we're going to flex the knee and we're looking for any reduction in range of motion or pain. We are then going to ask the patient to do knee extension by extending their leg and again looking for any pain or lack of range of motion. And then we're going to do internal, so we're going to move the leg in, and external rotation, so again looking for any pain or lack of range of motion. Okay, so what I'm going to do is I'm going to check for myotomes and dermatomes. So dermatomes are the nerve supply that supply kind of the skin, and myotomes are kind of a group of nerves that supply the muscle. So for this, what I'm going to do is trace my fingers down each nerve root, and what I'm going to do is check for kind of any abnormalities in neurological function on either side. So Alice, if you let me know if you can fill any of these. So what I'm going to do is, because it's affecting the lumbar spine and below, I'm going to check from T12. So let me know. Is that okay? Yeah. Yeah? Yeah. Yeah? Yeah. Yeah. Yeah? Yeah. 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 Okay, so by doing this, what we might see if someone had sacroiliac joint dysfunction is a numbness or pins and needles between S1 and S2 nerve roots, and because of the kind of subjective assessment, this would be present on the right side. So to check for myotomes for S1, we're going to ask the client to do plantar flexion of the foot. So if we get them to stand on one leg, any muscular weakness in this area may indicate an issue at S1. And then the myotome for S2 would be weakness in knee flexion. So if we bring the knee up and we ask the client to push back, then weakness in knee flexion would be indicated. So as the client has pain walking up and down the stairs, we should look at functional movement tests to see if they have any pain in these actions. So we're going to do a squat and a lunge. And people with SIJ syndrome can experience sharp pain during these movements, and so a positive test would be indicated by pain. So in the subjective assessment, the client indicated sharp pain down the back of the leg, and this could be caused by sciatica. So to test this, I'm going to do a straight leg raise, and if the client has any kind of sharpness in this position down the back of the leg, then this could indicate kind of sciatica. And to confirm this, what we'll do is we'll bend the knee, so we're taking the sciatic nerve out, and if the patient still has symptoms, then this would just indicate hamstring tightness, but if they don't have any symptoms, then this would indicate a sciatic nerve issue. And then based off this assessment, I will do a differential diagnosis. So based off the subjective and objective, I believe that it could be sacroiliac dysfunction, piriformis syndrome, or a radiculopathy. So this test is a standing flexion test. It's one of the tests that test for sacroiliac joint dysfunction. So what I'm going to do is I'm going to put my hands on Alice's PSIS. Okay, and then what I'm going to do is get her to flex forward, keeping her knees extended. And what I'm going to look for to see if one PSIS moves higher than the other. Come back up. That's it. So if both of them stay the same, then this is a negative test, but if one of them moves up higher, then this would indicate a positive test, and the one that moves up higher would be the affected side, and this test kind of looks for reduced mobility within the sacroiliac joint. Okay, so the next test is the supine long sitting test. So for this, what we're going to do is we're going to bring Alice's legs up into flexion. I'm then going to grasp the ankles and bring them all the way into extension. And I'm looking at the height of the medial malleolus to see if it is at the same height.
Then what I'm going to do is I'm going to ask Alice to sit up for me. And I'm going to look at kind of the heights, and what we can see is that a posterior kind of inominate is that the leg appeared shorter, will then lengthen when they sit up, and then anterior inominate, the leg that appeared longer will shorten when they sit up. So another test that can measure leg length discrepancy is the prone knee flexion test. We're not going to do that today, but this is a test that can measure the leg length discrepancy. The last of the 4 movement tests is a sit-in kind of palpation of the PSIS. So we're going to palpate PSIS to see if they are at different heights, and this can be observed as well. And the differences between the sit-in and the standing test is that they can look at kind of differentiation in symmetries, which could be affected by kind of differentiation in the lower limb. So there are 5 tests that we can do for the sacroiliac joint, and the first test is a compression test. So what I'm going to do is place my hands on the patient's kind of iliac crests and their ASIS, and I'm going to cross them over, and I'm going to apply an outward kind of pressure, nice and firmly, and this is going to pinch the sacroiliac joint together. If there's any pain or indication of pain on the patient's face, then this will indicate a positive test, and the sensitivity and specificity score of this test are both 69%. The second test is a distraction test. So for this one, I'm going to apply my hands to the same sides. I'm going to push inwards and up, and this is going to distract it, and the patient shouldn't feel any pain in this position because we are pulling kind of the joint apart. And the sensitivity for this test is 60% and the specificity is 81%. So the next test is the Gainsland's test, and this tests for hyperextension of the thigh. So for this one, what we're going to do is get the patient to bring their knee up to their chest, and then they're going to bring their other leg off the bed. They're going to flex their knee, or their hip, that's it, and we're going to apply a pressure to both their knee and their thigh. So I'm going to push down on their thigh and push forward on their knee, and this should produce kind of symptoms if the test is positive. So there might be kind of pain or discomfort, and then the sensitivity for this one is 77% and the specificity is 79%, and the positive test indicates an SIJ lesion. So the next test is a thigh thrust test, and for this what we're going to do is bring the patient's kind of hip into flexion and knee into flexion, and then going to place my hand underneath the patient onto their sacrum, and I'm going to apply a downward pressure onto their femur, and this, if it's positive, will reproduce symptoms and pain. And then for this test, the specificity is 44.4%. and the sensitivity is 74.4%. So the last test that would indicate an SIJ dysfunction is the sacral thrust test, and for this we're going to apply our hand over the sacrum. I'm then going to add the other hand on top, and I'm going to apply a downward pressure with shear force onto that area. And if this test is positive, it will reproduce symptoms and be indicated by pain. And the specificity for this is 67% and the sensitivity is 63%. And any of these 5 tests, once they've been done, if 3 or more are positive, then this could indicate sacroiliac joint dysfunction. The test that I'm going to do to rule out the piriformis is the Patrick's-Fabus test. So for this, we're going to put the leg into a figure of 4. I'm then going to use my hand to stabilise the other side of the pelvis. I'm going to apply a downward kind of pressure onto the knee to put the leg into full stretch, and apply small oscillations with compression, and this will put the piriformis on stretch. Any pain or lack of range of motion in this area could indicate a piriformis issue, and the sensitivity of this is 45% and the specificity is 51%. So based off the assessment, we can start to perform treatment, and treatment will depend on if the joint is hypermobile or hypomobile. So hypermobility is when there's laxity within the joint, so there's laxity within the sacroiliac ligaments, and hypomobility would be where there is stiffness in the joint. So for treatment, we can apply joint mobilisations in any of the positions that the tests were performed in, and you can apply small oscillations to the area, grades 1 to 4, depending on their stiffness and pain, and this can help to kind of free up and improve their range of motion. And then following this, there are specific joint mobilisations which we can use to decrease pain. So during the initial stages of treatment, I would recommend either using a hot water bottle or ice to reduce inflammation and swelling. I would then recommend that the client offloads the area or does activities which are less impactful. So for example, swimming, static cycling, or using the cross trainer. And I would also recommend a period of rest to allow for recovery. And then following this, we might be able to do soft tissue massage onto the area. So by looking at releasing the piriformis, this may help to reduce the sciatic symptoms. And also by doing soft tissue massage to the buttocks area and the lumbar spine, this will help to improve range of motion and improve functional ability. So a joint mobilisation that can be used is anterior iliac rotation, and for this we're going to get the client to lay on their non-affected side. They're going to bring their knee up to 90 degrees and then they're going to push against the therapist. What I'm going to do is put my hand onto their sacrum and palpate their PSIS. I'm then going to ask the patient to push against me and hold it for 10 seconds, and hopefully this will relieve symptoms, and then we can take it further to the point of bind. And then also what I can do is I can put both hands on and cradle the area to put in small oscillations and therefore increase the movement at the joint. So the next test that can be completed is the posterior iliac rotation. So for this, what we're going to do is I'm going to ask the patient to put their hand on the hip of the affected leg. I'm then going to rotate the patient so they're slightly on their back. I'm going to keep the bottom leg extended. I'm going to palpate using my hand on the sacrum and L5. I'm going to lift the leg up and I'm going to do forwards and backwards motions in small oscillations in order to free up the area, reduce pain and stiffness. So the next test is sacral nutation, and for this test I'm going to place a pillow under the ASIS on the symptomatic side. I'm then going to apply forwards and downward pressure onto the SIJ joint, and this is going to use kind of small or large oscillations depending on pain or stiffness, and I'm going to hopefully reduce the stiffness and reduce the amount of pain in the sacroiliac joint. Okay, so a joint mobilisation for sacral counter nutation is that I'm going to place my hand on the iliac spine on the symptomatic side. I'm then going to place my other hand onto the sacrum, and I'm going to apply opposite direction pressure onto both sides. And at this point I am kind of assessing for the end feel, and I'm hoping to improve the kind of range of movement and reduce the pain. So we can also use MET, so muscle energy techniques, and we can use post-isometric relaxation of the hamstrings and the lower back, and these will help to kind of reduce stiffness and improve muscular length, which in turn will help to improve functional ability and decrease pain. During later stages of rehabs, we can use core stability exercises and strengthening exercises to improve core stability, and this has been found to help with lower back pain and SIJ joint dysfunction. So Dink around 2011 said that the use of abdominal exercises and isometric abdominal exercises are the most effective, and using McGill's 3 we can put these together to give an exercise prescription. So the first exercise that I'm going to suggest is bird dog. So this is on all fours, and you can start with a small leg lift and then make it bigger as they progress. And then the next exercise is a side plank. So they would be on their side, and this is an isometric exercise, and they would hold it there. This is kind of more complex and this is easier. And then the last exercise would be a dead bug, and they are on their back with their arms and legs in the air, and they can do kind of opposite direction or they can do both at the same time, and then to make it harder they can put a resistance band around their feet and push out. So 2 strengthening exercises we can use are clam openers, so you'd be on your sides and you can open your legs up, and then to make this harder you would add a resistance band. And then we can also do fire hydrants, so you're on your all fours, and then you're bringing your leg out to the side, and you do this on both sides.
Following the assessment and the treatment options given, this should help to reduce the patient's symptoms and improve functional quality. If this doesn't occur, then we will look to reassess the area to find a different diagnosis.